Hello, everybody. I'm Emma Reynolds. I'm a cases GP for Gynae, and I'm here with Miss Katie Redford, who is a Gynae consultant specialising in menopause. So maybe I'll hand over to you to introduce yourself, Katie.
Oh, hi, good afternoon. Thank you very much, Emma. So yes, my name is Catherine Redford and I'm a consultant gynaecologist and the menopause lead at Sheffield Teaching Hospitals. I suppose people want to know my background into how I came into that, which is I trained at King's to do my menopause certificate with Deborah Bruce and Prof Reimer. And that was during my senior registrar's years. I undertook specialist training whilst I was spending my time up in Penderfields doing specialised surgical training in keyhole surgery. So I started my consultancy post in Sheffield in October 2022. And it has been a challenging few years starting as a new consultant, especially within the menopause service. And really, that's because we've had such high patient demand and popularity for the service. This seems to be a direct correlation, though, with the media support of women's health concerns over the last few years. Which has been wonderful and welcomed, but it has meant that we've had more pressure on our services and to deliver. So we know we recognise that we've got a lot to do with our Sheffield service to meet these demands. The things that we've done since the time I've been working there is we've now got 5 clinicians within the service, and we're currently hopefully undergoing some huge service improvements to improve the care that we can deliver to the women of South Yorkshire, because we're very aware that it's not quite where we would like it to be in terms of meeting that demand.
All right. Well, thanks for the introduction. And I'm just going to ask you a few sort of key questions about HRT, which will hopefully, upskill our GP colleagues. So I'll just go straight into them. So HRT, as you mentioned, has had a resurgence in popularity in the last few years. How confident are you that HRT prescribing is safe?
I think it's undeniable that HRT is an effective treatment for menopausal symptoms. But I think what we have to stress is that doesn't mean it's right for everyone. And it's sometimes picking that out that's the art of the job. The symptoms are caused by the body's decreasing hormone levels, particularly that decrease in estrogen. So we know that all women should have have access to good advice. They should be able to have a discussion regarding how best to manage their menopausal symptoms. That assessment should be holistic and individualised. But it needs to take into account the impact these symptoms are having on that woman's quality of life. I think making sure that we've individualised that HRT to the person is really important. And that almost is where maybe more of a tertiary-led service can come into play and help, because it's just having that extra layer of being able to really match even say different types of progesterone with side effects to that person, or taking into account some of those chronic illnesses and where the hormones sometimes lean on things like polypharmacy. So I think that's where we play our role. And actually, yes, I think I am confident with the use of HRT for women. I think women are taking HRT now for longer, and that does impact on that risk profile, and we need to remain mindful of that. So I think we've got really good data now to support its use, probably in what we'd consider the short term. And certainly we've got really good data, and we talk about having HRT up until the age of 60. But actually, we've got a huge cohort of women now taking HRT beyond 60, and potentially beyond when we think those symptoms would be impacting them. So I think it's that population that we really need to sort of take a pause and think about, and just consider the implications of HRT on their health profile.
Okay. But generally speaking, for a woman who is 50, taking it for 5 years without risk factors, it feels like a safe option.
Absolutely. It feels like a really safe space. Yeah.
Yeah. Okay.
I would completely agree.
Yeah. And I mean, you touched on this, but we know that HRT is more risky if we start at over the age of 60 or more than 5 years since a woman's last period. What's your advice when considering starting HRT in this cohort? Is it an absolute no, or?
No, I think if I keep that really simple, because if not, so like I said, I think they're over 60. So transdermal estrogens is your first line. Lower doses are suitable. Continuous or combined HRT, And then we don't really see much of it now, but tibolone used to be used a lot, and it is a brilliant drug. It's a brilliant drug. However, we don't use it in the over 60s. So we know that with blood pressure, tibolone impacting on stroke risk, that's sort of a no. So if you're getting towards your late 50s, that's the one that you're really wanting to switch over. There are, I mean, the BMS, which we use a lot, so the British Menopause Society absolutely advocate for women using HRT over their years of 60, and they've supported it by saying actually we're not seeing increased cardiovascular events, we're not seeing increased impact on cardiovascular mortality in that age group. I think only to balance that with your background risk increases with age. So we know that the older you get, the more likely you are to encounter venous thromboembolism. And actually the magic number of 60 suddenly jumps that up. So if you're looking at those profiles of patients per 10,000, it just jumps up at 60. So that impacts on endometrial cancer, breast cancer, and your background risk of venous thromboembolism. So I think the things that really impact on that risk when you're over 60 is lifestyle. So actually the poor ladies that are maybe struggling with their weight, smoking, more diet, that there are huge implications on that risk. And therefore, where does the HRT sit with that, with continuing it in that age group?
Okay. So sort of consider other risks and try and reduce them, and then have the lowest possible estrogen, and transdermally, I suppose, is
Just
the
increment
take
it
home.
up. I think it's starting low and working up.
Yeah. Okay. Lovely. So cases, we get a lot of referrals through for women who wanting to start HRT but have a history of either MI or stroke or PE. Is there any advice you can give us GPs on managing these women, or should they all come to you in menopause clinic?
So I was going to say service improvements, we will hopefully be introducing a clear-cut referral triaging system. But I think, yes, actually, I don't think it's unreasonable at all that we take responsibility for these ladies in the tertiary centre. So actually, strong history of cardiovascular disease, we really don't mind seeing them, because that is just another layer of complexity. However, straightforward things, so myocardial infarctions and strokes, then yes, actually you're wanting to look at starting low, going transdermal, using the anti-androgenic progesterones, or micronized.
I'm glad you can't say that.
And then actually it's the things that you'll have already done really well in the primary care setting, but you've probably already got these ladies, you've probably worked out whether they're hypertensive, made sure that's controlled, started your statins, offered lifestyle advice. But no, they are suitable for HRT. So within that cohort of women, we didn't see an increased risk of recurrence in the MIs. We didn't see a worsening of the outcomes of the MIs if they have them. So that was important, and that was reassuring for those ladies who had that history.
Okay. So if someone has had an MI in the last 5 years, everything is well controlled, cholesterol, blood pressure, and so on, we could start them on
I would start
transdermal
on
estrogen.
transdermal.
Okay, lovely. And again with PE, is that a different advice? Because I understood that trans.
No, I would go with the same. So the transdermal hasn't been shown to impact on that risk of VTE nor recurrence risk. So actually, yes, you would be safe with the transdermal, and then trying to pair that either with transdermal progesterone. So you're looking at your Fem7s, your Everol-Contis, so you can either go transdermal with your progesterone or try and avoid the androgenic progesterone. So go for an anti-androgenic progesterone, and always go body identical. So the Eutrogestans or the Geotrix.
And which are the androgenic progesterones?
So the androgenic ones, so norethisterone orally, medroxyprogesterone, but you can get those in patches. And the medroxyprogesterone, no, forget that one. But I was going to say you can always look to do a Mirena coil, because again that would count as one as transdermal. It's just you're not ingesting it. So you're wanting to, it's easier to say what you can use rather than what you can't. So you're wanting to go for medroxyprogesterones, Mirena coils, patches that are combined to avoid those risks.
Okay, so there's the commonly used ones anyway now, aren't they? Okay. I often see referrals for women who are already taking high dose estrogen, so 100 micrograms, but they feel their symptoms are poorly controlled. Do you sometimes use higher doses than this?
We tend not to, and I think it's because there are two things to consider when you're seeing these ladies, and that's is the delivery of the HRT, and then a bit contentious, but the absorption of that delivery. So often in the community, we've started things where they're safe, we've gone transdermal, and usually we're using a Utrogestan as well, because the community is brilliant at getting those safest start points.
Mhm.
So you then start to look at your patients and think, well, why are you still symptomatic? And usually they've seen you back again and we've escalated it. So we've optimized their HRT, but yet still they're symptomatic. So this is going to walk me into a trap of you're probably going to start to ask me about, do you check hormone levels?
Yes.
Actually, even if I don't check them, I'd be looking at it and thinking, well, you're using a patch and we've increased it. It's not working. So let's sidestep here. So then do I go on to a gel or a spray and what's going to give me the best efficacy in this patient? And then I'll work through other transdermals. But at the same time, sometimes when you look at these patients, if their risk profiling is low, so if we talk about the fit and well 50-year-olds or the 50 to 60-year-olds, actually I probably am not as scared to use an oral, and always tell them that probably as you get to your 60s, if you're in the community, they're going to see you with this and discuss moving you onto a transdermal, and also tell them that actually at that point your requirements are going to be lower, you may wish to continue or not, but it would be in your best interest to move to a transdermal preparation.
Okay.
But actually just giving them that short-term oral option if we think it's an absorption issue or we're just not getting appropriate levels for their symptom control. So I think, yeah, you're probably going to want to ask me about monitoring of levels now
I
and
am going
hormone. Yeah,
straight
that's absolutely
into
fine. But I think we've got to think, how are we delivering it? And are we getting good absorption? And would we do better with switching our transdermal preparation to something else? And if we do, what are we hoping to gain and what are we going to? Because actually, I don't think we go above licensing with estrogen levels very often. I know that's been a contentious issue, but I think it's because we've not needed to, maybe.
Okay. And that does lead into my next question, which was, do you ever use blood tests to monitor sort of HRT
Yeah,
absorption?
so I think where am I thinking of exceptions to the rule? So when are we using almost off-license dosing of estrogen? And it's probably if we're desperately trying to stick to a transdermal delivery, but actually we're still symptomatic. So we're optimizing our therapy, and that means that potentially, where are we at with our estrogen levels? Because the BMS have they've got a lovely article on this, but their levels are very variable. They can be very difficult to interpret. I was always trained to teach the patient, treat the patient, not the bloods. So I think we've got to keep that in mind. If you're looking at estradiol levels, there's a conversion to estrone. So are you getting a true picture? And measuring the just measuring that estradiol isn't going to give you a truly overall systemic look at your estrogen levels because of the different types. But that said, as a general rule, when I'm looking at them, I'm thinking they're going to be running between 200, 400 for good symptom control.
Okay.
Although there are always these satellite patients that will sit outside that. And I think classically, when we used to use implants a lot more, we got bigger fluctuations that rose outside of that range. So some will sit out of that. And what I would say is I don't tend to, if I see them over 800 and they're persistently that high, that makes me a bit more twitchy, and I start to consider where else is the estrogen coming from, or is this a risk for hyperplasia? What impact might this be having on breast proliferation? So if it's above 800, I start to think, are we running in the realms of unsafe, and also are we tachyphylaxis and not menopausal symptoms? So actually we've got a raised estrogen that we're then symptomatic of because patients feel lousy when they're running at that high. So generally, if I'm not getting good control with changes of transdermal preparations, I might sneakily check their levels to see whether I consider them low, being less than 200, or within a range of 200 to 400 to 600 that I think should be giving them adequate control, and then try and find something that'll nudge them up.
It's not something we would be expected to be routinely do in primary care.
Absolutely not. I
Yeah.
think that's a very academic, me meddling in clinic. I would not expect my colleagues in the community to be doing that. And I think if a lady is requiring that, then that's far too consuming for everything you have to manage in the community to do. So I think that
Lovely.
would be something that I am academically meddling with in the tertiary service.
Okay, we'll leave it to you.
Yeah.
Yeah. So what do you think about testosterone in managing menopausal symptoms? So we know it's only licensed for low libido, but do you think it has any other beneficial effects?
So not is it only licensed for low libido, it's only evidenced for low libido at the
Okay.
moment as well. So when you look at those randomized controlled studies, that's the evidence we've got is just supporting it in postmenopausal women, I might stress, for low libido and sexual desire and yeah. So that's the evidence we've got. That said, in the tertiary centre at the moment, I'm mentioning I've got 5 clinicians now. We're a 5-strong team. Some of those are very new clinicians, but myself, if I say on my books, which sounds quite old-fashioned, I've got 400 patients on testosterone. Very few are stopping. They all seem to tell me how much better they feel. And it's their cognitive symptoms, it's clarity of thought, it's brain fog, it's memory, it's energy, it's joints, it's nearly all of your menopause symptoms seem to be improved by the magical testosterone. But at present, I don't have the research to back that up. And the papers we've got at the moment don't. So yes, we're now using an off-license drug for symptoms that we've not got evidence to support in a cohort also that is getting younger and younger because the
Right.
demand is there. And I think that's what's become difficult about the testosterone and the
Yeah.
huge volumes. Yes, the media really drove forward with that. And then we both in the community in the tertiary centre have almost been on a treadmill keeping up with that demand.
Yeah. And I think I might just point out
Go
now,
on.
just while we're talking about testosterone, that there is an excellent shared care protocol on the CCG website for GPs who did want to start testosterone in primary care. And it's very clear about how to do it and the monitoring.
Yes, absolutely. I think I just had a thought as well. I think the other thing about the testosterone, which is the reassuring thing, is we've got no evidence that it causes any harm. So actually, at the moment, with no evidence that it causes harm, actually that makes my threshold a little bit lower with prescribing, because if I'm going to do some good for symptoms and I'm not going to cause any harm in the process, I'm quite happy to prescribe even when we're off license. And then the other caveat to that is checking levels, which is almost a nightmare for us to do in the tertiary service, but also a nightmare for you to do in the community, and the workload and the demand for that. But the levels, the criteria we've got are quite strict, but at the same time, even looking at the numbers and then pairing that with the side effects of patients. So actually patients are very good at saying, I just started it and I felt really irritable or anxious, or actually I really enjoyed it, but I did get that excess hair growth and symptoms versus that side effect. I didn't want the hair growth
Right.
at the site of use. So there are some things that naturally will stop ladies using it if they're particularly sensitive to it, or that are more of a reason to stop than, again, the numbers on the page when you're checking levels. And sometimes you get a higher reading, but your patient is absolutely fine with no side effects at all.
Yeah.
And yes, we don't have any long-term data really to say, oh, actually it's okay if you run them a little bit higher for 2 years, because we're still in the realms of not knowing how long these ladies are taking this testosterone for. But again, sometimes the higher levels don't equate to side effects, and these ladies are very, very happy. And that's because checking the levels gives you such variation, such wild variation in levels.
Okay. So once again, maybe treat the patient to some extent rather than.
Yeah,
Yeah,
absolutely. And yeah, probably feel a little bit more confident with that in terms of we're not seeing any harm with the use of testosterone.
that's very reassuring. So my next question, what is your approach to women who have a family history of breast cancer and wish to start HRT?
So again, it's following the BMS guidance on this and the advice we've already got there. But we know that So breast cancer is common. And once you've got to a certain age, I think actually just socially, everybody knows ladies who have had breast cancer. So it's that common that probably even in your social circles, you are knowing ladies with breast cancer. So that risk is high. And that risk is modified often more by environmental factors than it is by genetics. So the genetic population with the breast cancer is much lower. It's smaller. It's less than 10% of the breast cancers. We also know that the women with a family history of breast cancer, their background risk of breast cancer is not altered by the introduction of the HRT. So that cohort of ladies, there is no significant data at the moment to say that women with a significant family history of breast cancer have an increased risk of breast cancer if we offer them HRT. I think the caveats to that then become the population over 60, duration of use versus dose of use. So it's the duration of use of HRT. And I think that is probably where this might change in the future, because we have got ladies now using HRT for longer than that golden 5 to 7 years for symptoms, because ladies are taking the decisions now to use it for lifestyle, for bones, for overall health and well-being, actually longer than they ever did before.
Yeah. Okay. Thank you. So I just had a few other quick fire questions that just colleagues gave me to ask you. So I'll just finish off with those if that's all right.
Sneaky quick fire, okay.
Quick fire questions.
Let's hope I answer them quick fire then, because I'm a talker.
So Lenzetto, it's only licensed for 3 sprays. Can you use it more?
So this is cheekily because people go up to the 6 sprays, don't they? But there was some people said that, or some people said there was some data to say that over 3 pumps, you're not going to get almost a bounce in those systemic levels, even if you do start using more and more. There was also an idea that the Lenzetto, although in clinical practice, I really like it, and I think actually you do get good absorption and you do get a good sustained impact with it, because if we switch people from gel to Lenzetto, sometimes that really seems to be the key to success with their therapy. That said, on paper, the gel's meant to be sort of more, have better efficacy and be more better absorbed, give better sustained levels than the Lenzetto. I think the reason why this is the delivery. So actually, with your Lenzetto, it's easy to deliver. It's got the lovely hood on it. You place it on the thin skin and you move it along, and it's quick, easy, dries in, absorbs, no problem. The gel, when you start using more and more gel, you are almost covered in gel. It's wet, it's blobs, it takes longer to dry in. You probably are wiping some off somehow. And I think that's the difference. The Lenzetto is just easier to use than the gels sometimes when you're using those higher doses. But again, it's not often we're needing to go up past the 3 pumps, because actually I think if you've still got symptoms and we're starting to go outside of licensing, we've kind of got to look at why in delivery and is there an alternative?
Okay, thank you. And then the drospirenone, the new progesterone pill, Slind. Do you sometimes use that as the progesterone component for HRT?
Oh, yes, I'm starting to really like this. And the reason why is because it doesn't have the side effects. So it's given me another weapon, because actually sometimes if I'm seeing them in tertiary care, it's because something like the Utrogestan, which is loved by lots of women and brilliant and safe, is giving them side effects.
Yeah.
So actually, I've then got to troubleshoot what can I give that will also give the flexibility with the estrogen product, but give safe endometrial protection, low side effect profile. And the drospirenone, the Slind, it doesn't have the same, it's the anti-androgenic, it doesn't have the same side effects. It seems really well tolerated. And then also has the added caveat of being a contraception. So you've got the contraception plus the endometrial protection. And although it's not licensed for that, it's got good data and is recognised for doing that. So I think we are safe to use it. And I think it's actually a secret to success with some patients, because it gives you another option, which allows you to give them that flexibility back with their estrogen product, which should be doing the good work. You almost want that progesterone to be the unnoticed, the silent partner that's just keeping that endometrium safe.
Oh, excellent. I will start using it.
Yeah, no, I get it. So I find myself writing it quite a lot,
Yeah.
and then I don't want to, yeah, teach grandma to suck eggs, isn't it? But yeah, I didn't know how has word spread yet that we have another weapon.
Yes, well, very useful one. The next question. So just about cutting patches in half. Do you have any view on that?
You know what, I feel like Sue might roll her eyes at me, Dr. Stillwell, but no, because I feel like sometimes women really like having a patch and it's very easy for them to use, and sometimes the gels aren't user friendly. And the patches, it'll then just give you that halfway house in dosing. So when I trained in London, I feel like they did it a lot down there because it just gave you that nudge up. But the other thing is yeah, so I don't mind, and as long as they're sticking or they're getting the absorption or they're getting the symptom control,
Yep.
yeah, we're not meant to, but I don't see the harm in it. I think is the point. Is like I agree it's not perfect, but
Yep.
is it harmful? No.
Good. Thank you. And did you have any top tips about the best application sites for different topical estrogens?
We're always going for thin skin. Now, I must say, bless Davina McCall, she did a video on YouTube where she slaps it on a deltoid and rubs it in frantically. And I'm not sure I would go with that approach. So I would always pick thin skin. So I'd go on the underside of an arm. I'm doing it now, or the inside of a leg. And sometimes with the lenzetto, you're wanting to spray and then move along a little bit. But the gel, actually, you're just wanting to squirt it onto a palm and literally smear it down the leg or
Okay.
smear it down the underside. Because I think when you start rubbing it in, it's like, are we rubbing it into our hand or into our arm? I think the tougher skin, I can totally see why you might not get as good absorption on your deltoid as you would on that thinner underarm skin.
So, Katie, thank you so much for that. It's been really helpful. I'm sure lots of people have got lots
So I
from it,
hope I've not
and
let Sue down.
I
I'll
very
have to
much
make
doubt
Sue
you will
listen and
have.
she can critique it for me.
So thank you so much for your time. Thank you.